everyone. My name is Christine Kennedy, and on behalf of the Alumni Engagement Office and the McMaster Optimal Aging Portal, I'd like to thank you for joining us this evening as we hear from Dr. Randi McCabe, a leading researcher at McMaster in the field of clinical psychology. This talk is part of a new health and wellness series, and we are pleased to be partnering with the Optimal Aging Portal on many of these talks. Dr. Anthony Levinson, I'd like to welcome him. He will be moderating tonight's webinar with Dr. McCabe. And many of you may be familiar with Dr. Levinson and his smiling face, as he has been a guest speaker in the past. And we're always so thrilled when he graciously offers to be part of our lectures because he is a very busy man. He is a professor here at McMaster and is a neuropsychiatrist practicing medical psychiatry in Hamilton. He's also the director of the Division of E-Learning Innovation in the Faculty of Health Sciences, and he's on the leadership team of the McMaster Optimal Aging Portal. Thank you, Anthony, for joining us. I'll let you introduce Randi, and we'll get into the topic because it is one that certainly has resonated with our alumni and Hamilton and greater communities.
Thank you so much, Christine. It's great to be here. And thank you all for joining us for this first Portal Alumni Association combination webinar. It's a real pleasure to have Dr. Randi McCabe with us tonight. Randi's a professor. She's the academic head of the Anxiety Division in our Department of Psychiatry and Behavioral Neurosciences here at McMaster University. She's a clinical psychologist. She's also the director of the Anxiety Treatment and Research Clinic at St. Joseph's Healthcare Hamilton in Hamilton. Dr. McCabe's research encompasses a real focus on anxiety disorders, assessment, as well as the development of novel cognitive behavioral therapy, or CBT, interventions for a range of disorders. She has published over 190 peer-reviewed papers. She's published book chapters and 9 books, including a recent one on cognitive behavioral therapy in groups. This talk, as I mentioned, and Christine did, part of a collaboration around the McMaster Optimal Aging Portal. So we'll be talking about evidence. And I also want to thank you, the attendees, for sending in questions before the session today. So that was excellent. And we have adapted and tailored the talk today. Dr. McCabe's tried to incorporate answers to many of your questions during the presentation. We'll try to answer as many possible after the presentation. And then my colleagues and I will also be developing an e-learning lesson that will be available through the portal that will talk in a little bit more depth about anxiety generally as well. So without further ado, Randi, take it away. It's great to have you tonight.
Thanks, Anthony. Good evening, everybody. It's really a pleasure to be with you tonight. Although I can't be in person, I think we have way more people than if it was an in-person event. We have over 650 people on this webinar. And the topic is anxiety, which is near and dear to my heart, not necessarily in a good way, because sometimes anxiety is bad. And that's what we're going to be talking about tonight. What can you do about it? What is it? What can you do about it? And specifically cognitive behavior therapy, which is why I find my work so rewarding, is because there are really effective treatments for helping people manage, reduce, and even eliminate pathological, I'll call it, anxiety. Because as I told Christine at the beginning when we were pre-meeting, everybody has anxiety. We don't want to necessarily get rid of all of it because it actually helps us. So we'll talk about that as well. And so just to provide a disclosure, so I'm a professor in the Faculty of Health Sciences in the Department of Psychiatry and Behavioral Neurosciences at McMaster University, and I don't have any for-profit interests to disclose, and my current funding is from the Canadian Institutes of Health Research, or CIHR. And at the end of this webinar, I'm hoping that you'll really have a good understanding of the nature of anxiety and when anxiety goes into that clinical range where intervention may be needed. You'll be able to understand what is cognitive behavior therapy and how do we use it to treat people having anxiety disorders. And also, what are the resources if you or your loved one wants to find where do I get a CBT? How do I know I need it? We're going to provide lots of resources on different formats and ways to access CBT. So we'll start off with a poll. So I'm going to hand it over to you, Anthony.
Yeah. Shelley, can you put up the first question, please? So question 1, And question 2, which of the following conditions are a concern for either yourself or a loved one? You can select all that apply between anxiety, depression, stress, insomnia, or chronic pain. And then question 2 is more of a true-false question. Panic attacks are only associated with panic disorder, true or false? So we'll give people a few seconds to answer the poll, and then we'll review the results. So just a quick summary, it looks like anxiety, perhaps not too surprising given the topic of the webinar, but 88% are concerned about anxiety as a topic. And you can see the overlap, which you'll talk about, between stress and anxiety, but also high levels of concern around depression, insomnia, and chronic pain. And then our not so trick question, but people are pretty savvy that panic attacks can be seen in other disorders apart from panic disorder, which you'll be talking about a little bit later.
Right. Thank you. So there we go. We can see that everybody's got a lot going on, including me and probably Anthony and everybody else, right? Because what a world we're living in right now. So just moving along, let's get started. Anxiety and fear are universal. We all can relate to them because we all have them. They're very adaptive in some ways. So when you have anxiety, it helps motivate you to prepare for some sort of threat that's either in the near future or even more distant future. And right now, I think one could say we're all living under existential threats in terms of, first of all, the pandemic, and at the beginning of the pandemic when we didn't know what we were dealing with, and just to the state of the world right now and the uncertainty, because with anxiety is usually triggered by uncertainty, and you know, more now than ever that I can remember, it's kind of uncertain where things are going, where is inflation going, all sorts of nuclear Armageddon, like lots of things are happening that we haven't actually had to confront for decades probably. And so anxiety does have that adaptive quality. However, when the threat is ongoing or chronic, then and you don't get any relief from it, anxiety can become more of a persistent problem and start to interfere with your life. And we'll talk about when do you go into that range. And then fear, you know, people have fears. They're adaptive. They protect us from doing dangerous things. You know, it encompasses that fight or flight reaction. So when you are confronted with an immediate threat, so if you were crossing the road and all of a sudden a car was coming right at you, your fear response, that fight or flight response, would motivate you and mobilize your physiological resources to get out of the way very, very quickly. Or in the case of a situation where you had to defend yourself, and in some cases freeze. So that fight, flight, or freeze reaction. And we all do have that, and it is adaptive. So we can all relate to some, or not, if not all of these symptoms of anxiety. And that was some of the questions that I was seeing is, well, how do I know this is anxiety? Anxiety and clinically, clinical levels of anxiety, it's like a diagnosis of exclusion. You got to rule out anything medical, because look at these symptoms. It's pretty much, you know, crosses everything, like to feeling tensed, keyed up on edge, having a racing or pounding heart, feeling shaky. There's cognitive symptoms, like feeling like you have difficulty concentrating, you can't pay attention, you can't remember things, and that could be because you weren't concentrating to even take in information. It can affect your sleep. You can feel feelings of unreality, like things are really strange around you, or you're detached from what's going on around you. You're in your head thinking about something that's making you anxious, or depersonalization, where you feel like you're almost watching an interaction that you're in. Those are very common. A number of the questions asked about, you know, abdominal GI type symptoms and anxiety, and the gut microbiome, the gut response. And we know anxiety and fear are really connected in physiologically, in that adrenaline fight or flight response to mobilizing, you know, your body, that it does affect your gut. Like it's almost directly related. And so when you're really anxious, you might have to go to the bathroom. You might have to go to the bathroom multiple times when you're anxious. And so absolutely, you know, you can see those gastric symptoms, and people who have chronic levels of anxiety often will go for investigations. Do I have irritable bowel syndrome? Like you can have both overlapping, of course, but anxiety can cause people to feel like they have that, and vice versa. So that's important to know. Now, intense episodes of fear, what we call panic attacks, I'm going to talk about that on the next slide, but you all seem to know that you can have panic attacks in, across different types of anxiety disorders. There's cognitive symptoms of anxiety, fearing that something bad is going to happen, that you may lose control in some way, you could pass out, something bad may happen to you or your loved ones, lots of cognitive worries, and that these worries can seem uncontrollable, and feels like catastrophes are going to happen. And we're going to talk a bit about the different types of cognition or thoughts that people have when they're feeling anxious. And then avoidance. So when people are anxious, they may start avoiding the situations or activities that are linked to the anxiety, because we're really smart. If we associate something with anxiety, it's natural that we're going to want to avoid experiencing that. Now, panic attacks are, here I have the symptoms here in this orange box. Many of the symptoms, all of the anxiety symptoms you can see in a panic attack. The actual definition is that you get a rush of these symptoms and they peak within minutes. It's like a rush or a wave of fear that comes all across your body. And it's very, very intense. It's so intense. It's very scary. Many people think, what's wrong with me? Something's catastrophic. Maybe I'm dying. Maybe I'm having a heart attack. People quite often go to the emergency department to see, because they actually think there's something physiologically wrong, because often a panic attack will happen out of the blue when you weren't expecting it. And then you think, well, what's going on with me? And one study, a community sample of over 10,000 people, found that 22%, so more than 1 in 5, almost a quarter of people had a panic attack just at some point in their life. So panic attacks are very common. And they can just happen here or there periodically, or they can become more of a problem. And we're going to talk about that as well. There was the Mental Health Commission of Canada has been doing these surveys throughout the pandemic. They're in the 7th or 8th wave of these surveys. The last survey was in January of this year, where they're just surveying how are people feeling during the pandemic, just general. And what they found is that over a quarter of Canadians across the country report feeling mild to moderate anxiety, and similar levels for feelings of loneliness and depression, which is much higher than pre-pandemic. And it's not surprising, because the pandemic has had all these kind of after effects. Some people describe, a wave of mental health impacts from the pandemic, but we also see globally just sorts of the impacts to supply chains and gas and inflation and all sorts of things that you can imagine. It makes sense that we'd be feeling, these feelings. And what's interesting is almost a quarter of people wanted care, like they want to get help. How do I feel better or get help with my coping? But we're unable to find or access services. So there's services out there, but people don't know what they are. And that system navigation is a real issue. And so we're going to talk about what are some options if you may be interested in knowing about services. And if people want to read that survey, there's a link there in the slide. So as I said, anxiety and fear are normal everyday experiences, but when do they cross out of the normal range? When might you think, gee, I think I got to go talk to someone or get some help with this? And, there's some indicators of that. So if you feel that your anxiety is excessive, given whatever the situation is, like right now, it's kind of normal to maybe feel a little bit of unease just with what's happening in the world, or maybe you have a situation coming up where you're feeling anxious and it makes sense because, for example, my son had a test today. So yesterday he was, was tense, stayed up late studying, was feeling anxious, but then today he wrote the test, he feels good, his anxiety's gone. So that's normal levels of anxiety. If someone had anxiety that's too much and they can't, function, then that's, a sign that you might need some help. Does the anxiety reduce with rational explanation? So if someone's really afraid of a particular symptom, like I'm really worried, like, my one son, he, gets worried about a symptom, like I have this thing on my face, what is this? And you explain, oh no, that's just a normal blemish, and the anxiety goes away, then that's fine. But if it persists despite rational explanation, then, that may be a sign that it's moving into the clinical range. And as I mentioned, if it causes you a lot of distress, if you're worried about your worrying, or you're feeling like I'm so anxious, I can't enjoy my life. I can't, if it starts for some people interfering with their ability to go to work or go to school or do activities they like to do, if they stop socializing, That's also a sign. And then if the anxiety is persisting over time, like we may go through periods of life when there's more stress and you're feeling more anxious, but then it goes away. But if most of the anxiety disorders have a specifier of if it's persisting at least 6 months. And so if any of these apply to you or someone you love, that would be a time where we think, okay, you know what, it makes sense maybe to go get this further investigated. And as I said, anxiety, we all experience it, but anxiety disorders, that clinical level anxiety is actually one of the most common mental health conditions. However, even though it's most common, it's often under-recognized and undertreated. So even, if people have it, they may not even know that, oh, this is what I'm experiencing. It's anxiety, it's an anxiety disorder. Or if they do, they may not know what treatments there are. And so the global prevalence, based on a review of across 87 studies in 44 countries, found when they assess people right now in the current state, 0.9, so 1% to 28% of people were experiencing an anxiety disorder. And when they asked in your lifetime, have you ever had an anxiety disorder? It was the numbers range from 2.4 to 29.8%. So the prevalence rates are really high at the upper end. Like it could be as high as almost 1 in 3 people have had an anxiety disorder at some point in their life. And it's across different cultures, and that's what the countries show. It's not just unique to kind of a Western culture. Now, the syndromes may look a bit different depending on where a person's from and what's kind of normative in that country, but it is very universal. And when we talk about anxiety and anxiety disorders, there's no one anxiety disorder, and you'll see this huge list. There's actually lots of different anxiety disorders that you can have, so no wonder the prevalence rate's so high. Each of them have a lot of similarities. So all the anxiety disorders are characterized by those symptoms of anxiety, and for each person it's different what symptoms they experience. People also may engage in avoidance behavior across all of these anxiety disorders, and they also may engage in safety behaviors, which is various different behaviors they may do to help feel less anxious, whether that's checking behaviors, checking with loved ones, seeking reassurance about their worries, carrying certain things like always going out, with a phone in case something happened to you. Now, everybody carries their cell phone these days, but there's things that people may do, what we call safety behaviors, to feel less anxious, but that they can actually maintain the anxiety disorder. So each of these anxiety disorders, although they're similar and have commonalities, they're all different in where the focus of fear is. So what is the person particularly afraid of, whether it be a situation or a trigger, is what is for the most part, the differentiating factor. So in specific phobia, people are afraid of a specific situation or trigger, like heights, or seeing blood, or flying in an airplane, or driving, okay? So it's always, or it could be an animal, like a phobia of dogs, storms, all different things. It could be really anything, but it's a very discrete fear. Whereas in social anxiety disorder, people are very, anxious about social situations where they may be negatively evaluated. So they may avoid a number of different situations or feel very uncomfortable because of that fear in social situations. They could do the situation if they're by themselves, but when other people are around or unfamiliar people, they may feel anxiety. In panic disorder, people are focused on the fear of the panic attack itself or panic symptoms. And it often goes hand in hand with agoraphobia, where people want to avoid situations where they may experience panic symptoms or panic attacks. In generalized anxiety, people are really concerned about bad things that might happen, worries about being in a car accident, worries about being late. It could be everyday worries about not being able to pay the bills, even though that they have enough money to do so, worry about bad things going to happen, and so on. So I'm not going to go through each one, but each of these anxiety disorders has a different focus of the person's concern, and that's what distinguishes them. And up in the right there, you see the DSM-5, which is the Diagnostic and Statistical Manual for Mental Disorders. That's where we actually have the actual criteria for each of these disorders. And in the most recent edition, which is the 5th edition, obsessive compulsive disorder and post-traumatic stress disorder, which are at the bottom there, were actually taken out of the anxiety disorder section and put in their own kind of chapters. So obsessive compulsive disorder is in a chapter on its own with other different disorders that are more impulsive, like hair pulling, which we call trichotillomania, and a couple other disorders, more of impulse control. And post-traumatic stress disorder is in a chapter which really focuses on the fact that this disorder is really a response to external events. So you can't have post-traumatic stress disorder unless you've experienced a traumatic event, and then you have a stress response. So just want to point those two out, but they're really related to the anxiety disorders. Now, a number of questions asked about, well, what about my loved one who has dementia or Alzheimer's and they're having a lot of anxiety? What about, my loved one has, been having heart disease and is having anxiety, or, lots of questions about that. And I wanted to point out that anxiety can be, represented as what we'd call secondary anxiety in relation to all sorts of different syndromes, whether they be other mental health conditions. For example, people may have a syndrome called borderline personality disorder. There's a lot of anxiety present associated with that disorder, or in eating disorder. People are anxious eating, or related to their symptoms. But that's not an anxiety disorder in the ones that I just reviewed. It's just part of that other syndrome that they may be experiencing. Or with dementia and Alzheimer's, that may be related to the, changes in the brain that are happening that cause anxiety. Or it may be for people who think Alzheimer's, they may feel like they're aware that they're losing their memory, and that makes them anxious. And it's what we would call secondary anxiety. The treatments I'm presenting may help and may not help in those cases because the anxiety is caused by something else. Anxiety in the context of a terminal illness, for example. So in those cases, sure, there's anxiety, but we would be really conceptualizing it in the context of what the primary syndrome or condition is that we'd want to be focusing the treatment on. With this chart, I just really want to show you, here's the prevalence rates for the lifetime for panic, agoraphobia, social anxiety, generalized anxiety disorder, and phobia. And you can see when you add them all up, 33%. So that's where we get that 1 in 3 people will have had an anxiety disorder in their lifetime. So that's us or our family members, right? It's 1 in 3. That's a really high number, which is why we got so much interest in this talk, I think, because people can really relate. Like I have a child with a lot of anxiety, and I'm constantly helping him manage that. You can also see here what are the more common ones. So social anxiety and specific phobia are the most common anxiety disorders. Here's a slide showing prevalence in older adults. And what's interesting here is you can see it depends on the age. So age 55 to 64, the prevalence rate based on this study was about 7, jumps up to almost 14 at 65 to 74, and then back down to around 10 at 75 and above to 85. And you wonder, well, what's going on there? Well, what's happening during 65 to 74? People are having a major life transition. And I just wanted to point out that you always got to factor in stage of life and, what's happening in your life, when we're looking at anxiety, because, when you're having a transition like retirement, or maybe someone's partner passes away, those types of things could trigger anxiety later in life. And I'm going to be talking a bit about that actually based on people's questions. There's a lot of questions about late life anxiety and anxiety in older adults. And so turning to that, we see that the community prevalence rates are about 3.5 to 10%, of people, older adults, may be experiencing anxiety. So it is lower than the general rates, but it's still not insignificant. And the studies find that in people who are homebound or in long-term care homes, hospitals, or who have a chronic medical condition, the rates are higher. The most common anxiety disorder in older adults is generalized anxiety disorder. So the worries, and you can kind of understand that when you think of all the things that are happening when, as you age, your health is maybe deteriorating, loved ones may be having health problems or passing away. There's financial impacts if there's no longer income coming in. There's all sorts of things. I could go on another talk about that. And clinically significant anxiety symptoms are even higher. So 15 to 20% in community samples, and over 40% in individuals with disability or chronic illness. However, what was interesting was when I was looking at that study across Canada of how Canadians are doing during the pandemic, older adults actually fared much better than younger adults. So I thought that was very interesting and reported lower levels. They still reported significant levels, but they weren't as high as, people less than 65. So they reported having better mental health, stronger coping skills, and were less likely to engage in problematic substance use. So I thought that was interesting. The other thing I want to point out is that anxiety is very highly comorbid with depression. They often go together. And that makes a lot of sense. Like, they have a lot of overlapping symptoms. And also, if you're very anxious, of course, you're going to get depressed. And if you're feeling depressed, it's often likely that, you start getting anxious because of the different changes that you may be experiencing. Here's just a case of what is happening to me. Jason is a 58-year-old man. He is married with 2 children, and he was out golfing one day when he started to feel strange. He felt anxious, like something bad was going to happen. And it was hard for him to focus on his game, or, his buddies were engaging in small talk. It was really hard for him to focus. And he felt that rush of intense physical symptoms, and he thought he was going to pass out. His heart was racing, he was sweating, he was shaky. He tried to pursue, but his head kept thinking, well, what's wrong with me? And on the 9th hole, he thought, this is it, like something bad's going to happen. I have to go home. And when he got home, he felt much better. But he started to worry, well, what if that happens to me again? What if there's something wrong with me? And a few days later, a similar episode happened at work, and he thought he would pass out. So he started to avoid social activities like golfing, going to his kid's hockey game, for fear that he would become incapacitated. And he started to get a chronic level of anxiety all the time, thinking, how am I going to feel this today? What's going to happen? Such that each day became like a struggle. And he really just felt like, will I ever be normal again? He found it difficult to concentrate, function at work, and eventually he went on a medical leave. His doctor investigated him to see, is there anything going on with you physically that may be accounting for these symptoms? But there was nothing abnormal in the medical assessment. And so Jason was referred to the specialized anxiety clinic for assessment. I just wanted to point out, this illustration of how panic disorder can start at age 58. And he developed agoraphobia, like he stopped going in and engaging. And, the good news is, I'll come back to Jason with treatment, he made a full recovery. But I just wanted to show how debilitating this can be. And that's kind of a broad overview of anxiety disorders. And now I'm going to turn to, well, what do we do when you have an anxiety disorder? And I really want to point out this really important resource, which is the Health Quality Ontario has a family and patient guide for what is anxiety and what do you do about it? What does good treatment look like based on evidence? And it goes through what are the standards of care that you should expect if you have, or you or your loved one have anxiety. And, it goes through identifying and assessing it, getting support for the person and their family, a stepped care approach, meaning that we start with the lower intensity option and move to higher levels of intensity of treatment as needed based on the person's needs or preferences. Then move to psychoeducation or self-help interventions, which I'll talk a bit about in a minute. Cognitive behavior therapy, which is the first line treatment for anxiety disorders, and also medication. So it's a really great resource, and the link's there for you. And now we're going to move to another poll.
Thanks, Randy. Shelley, do you want to put up the second poll? So, a couple questions related to the next part of our talk. How familiar are you with cognitive behavioral therapy, or CBT? And then question 2, another true-false question. Family members may unintentionally reinforce and exacerbate their loved one's anxiety symptoms by engaging in accommodation behaviors. True or false? So we'll give you guys a few seconds to answer this poll. Just to let you know, I'm trying to answer some of the questions in the Q&A during the presentation, and then we'll take some time at the end of the talk for Randy to answer some more of the questions that have come in. So that's not bad in terms of some familiarity. A lot of people are somewhat familiar, but about half the people are not very familiar or not familiar at all. And Randy's going to change that by the end of the talk. And we're not fooling anyone with these true false questions tonight.
This is a smart audience, Anthony.
I know.
Yeah, so family can play a major role, and not, of course, unintentionally, in actually reinforcing and maintaining the anxiety by engaging in various what we call family accommodation, where if you have a loved one who has anxiety and maybe they check with you a lot and you give them information or reassurance, or maybe you, I had one person who, they had a fear of having an accident in their pants, like going pee in their pants. And so this was a teenager. And so the family would always, stop 5 times on the way to a distance, like do all sorts of behaviors to accommodate her fear, which actually kept reinforcing it. So yeah, there's all sorts of that's an example of, you can have a fear of anything and nothing would surprise me. And but family and being very well-meaning, because when your loved one is upset, you want to do whatever you can to help reduce their distress, and that may inadvertently reinforce it. And it's quite often avoidance. You can see that in kids when they're going to school. Okay, you stay home today, and then that starts a whole school refusal thing that's based in anxiety. So we're going to talk about what the treatment is for that. So moving on now. Here we go. And that's why that guide is a family resource too, because it's really good for the family to know what is anxiety, what's the treatment, and how can I help. So CBT, Cognitive Behavior Therapy, is a first-line treatment. As I mentioned, there's years, decades of research. There's thousands of studies now across anxiety disorders showing its effectiveness. It's based on usually a treatment protocol that the therapist would be following session by session. And based on the specific anxiety disorder. However, there are transdiagnostic approaches too, that one protocol could treat a couple of different kinds because they do have those overlapping symptoms. What they do is really look at what is the person's thinking patterns and behaviors that are maybe contributing to and maintaining the anxiety. So there's that idea of that interaction between the thoughts, feelings, and behaviors that we then look more closely at. And you want to have a professional who's trained in CBT providing you that treatment. Because there may be people who say they do CBT because they went to a few workshops, but if I was going to get CBT for my kid, I'd be, okay, where's a certified CBT therapist? And I have a resource, it's in the resource guide of how you find one. We have a list of people certified across the country through the CACBT. And also feel free, if you were going to see a therapist, to ask them, what is their training in CBT? Sessions vary in length. They're usually 1 to 2 hours. In a group type format of CBT, it would be 2 hours, and one-on-one, it would be 1 hour. Unless say in PTSD, sometimes we do 90-minute sessions. And the typical duration is 12 to 15 sessions. And sometimes we incorporate family members for psychoeducation and how to support their loved one through the treatment. And it's CBT is a range of different strategies that are basically selected and put together as a package based on what the symptoms are. In older adults, it offers a really good alternative to medication treatment, because when you're getting older adults may be already taking a bunch of medications, may not want to add another one on board. And so CBT would be a good option to try. However, if there are more medical conditions present, it may just be a complicating factor for some of the strategies, for example, an exposure. But we know that it is more effective than no treatment or placebo. When someone thinks they're getting a medication, it's actually a placebo medication. It's not a medication, it's a placebo, a sugar pill. And CBT is more effective than that. However, there's very little research in this area, unfortunately. So we don't know for sure. It is promising, but it may be less effective. So the effect may not be as strong or as robust in older adults. But I really do feel like the jury's out. It's too early, to say that for sure, because the research is limited. We need more research on older adult populations. Now, here's the CBT model. Somebody asked, well, how do I, get anxiety? Is there a genetic factor? And here in these green boxes, you can see that there's all sorts of vulnerabilities that can predispose you to having an anxiety disorder. Biological, whether that's, your genetic, background in terms of whether you have a heritability from family members who may have been anxious, like your mom or your dad. So you can inherit genes. They're not specific to specific anxiety disorders, but more general. So you may have an anxiety disorder different than your parent, but they're both in the anxiety realm. There's psychological vulnerability factors. So certain personality traits may increase your vulnerability. If someone is more perfectionistic, or they're higher in a trait we call anxiety sensitivity, where people are more sensitive to their physical sensations. And then also social factors, different things in your environment that may cause you a lot of, challenge, may increase your vulnerability to developing an anxiety disorder. Different events that happen, as I said, like traumatic events could trigger PTSD. And then there's learning experiences. The things that happened to you growing up, or that you saw, or that you learned from watching the news, can also influence someone to develop an anxiety disorder. For example, seeing a parent who's very fearful of snakes may transmit phobia to their child. So that's one example. And so you have these factors on board, and then often anxiety disorders start after or during a time of stress. And somebody asked about, well, what's the difference between stress and anxiety? And they're very overlapping, but stressful events can be positive or negative. You can have, like, even say planning a wedding, which should be a positive event, can cause you stress, and it can cause you a whole bunch of symptoms that look like anxiety. But once the stress is gone, the stressful event is over, you feel fine. So stress is your body's reaction to events that happen that could be positive or negative that disrupt your equilibrium. And in anxiety, people often come for treatment. They go, I have anxiety, I can't manage it, what should I do? And we really like to teach people, well, we can break down anxiety into these three components: what you think, what you do when you're feeling anxious, and how you're feeling in the body. And that's the very first step for us in helping people see, oh, if I break this down, it's more manageable. And now that's how CBT works. We start to target each of those purple boxes there on the bottom. So for example, we think back to Jason, who, had the panic attack while he was golfing. He had, we often use in CBT self-monitoring, where we get people to record, times they're anxious, so we can start to really unpack what's happening. And he had an experience where he was at work, he was feeling hot and dizzy, and he had the thought, there must be something wrong with me, something bad's going to happen. He actually left the office and thought in his head, he went out to his car and thought, I can't go back in there. And so his behavioral response was, he started really, when he started feeling hot and dizzy, he started monitoring the more symptoms in his body. And guess what? If you monitor your body, you're going to find more symptoms. He escaped the situation by going out to his car. And guess what? When he escaped, the physical sensations of anxiety, depersonalization, derealization, racing heart that he was having reduced, and that reinforced him to avoid and want to not go back. And so we can see how by what happens with those thoughts and behaviors can amplify anxiety. And with CBT, we start to intervene there to actually reduce it. So we're changing up how people respond to the triggers. And so, as I mentioned, CBT is a whole collection of different strategies, with each one focusing on a different target. So the very first step is psychoeducation, and you'll see in the resource, there's tons of different workbooks that we've outlined there. People, by really getting a good understanding of what's happening with their particular anxiety problem, they feel more equipped to how to manage it. And so psychoeducation is a very good first start. And then we start focusing on those cognitive thoughts, those thinking patterns, and try and reduce anxious thoughts and promote more balanced or different ways of responding to the trigger of the anxiety. And that also increases people's belief in their ability to cope. The next thing we want to do is really tackle avoidance and, using exposure strategies. And that by people practicing being engaging in what they're afraid of, they actually start to build confidence and it reduces their anxiety. We also look at other coping skills, like some people may need social skills training or assertiveness training, or maybe help with problem solving if they have a lot of worries but don't know how to effectively manage actual stressors that they may be facing. And finally, we do use relaxation-based strategies when people have too much anxiety that they can't engage in treatment. But for the most part, relaxation isn't really a core component of anxiety treatment. Most people who come to our clinic, they've already tried relaxation, it didn't help. And in fact, sometimes it makes it worse. They get what's called relaxation-induced anxiety. They're trying to relax and then they have more anxiety. So that's a nice overview of the different strategies. And if we kind of target in more on the cognitive strategies, that self-monitoring, becoming more aware of what we're thinking. Usually we're in autopilot, we're not thinking about our thinking. That's really key, because once you start to look at how am I thinking, how am I responding, then you can start to identify and challenge these thought patterns and consider other ways of thinking. It gives you a lot of control. In anxious thoughts, people are predicting some threat is going to happen. Now, if that was the only thing happening, they wouldn't get too anxious because they'd be like, oh, I think I can deal with it. You have to have that other piece to the equation where you feel like something bad is going to happen and I won't be able to deal with it. And so, and when it does happen, it will be really, really bad and I won't be able to deal with it. So I won't be able to cope, I won't be in control. And so there's those two parts to the equation there for anxious thoughts that we target in cognitive therapy. And the two common distortions we see in people's thinking patterns is something called probability overestimation, where people overestimate the chance of a bad thing happening. Like in social anxiety, people think I'm an idiot. Well, people rarely, that may be a much higher prediction than really the actual probability. However, even if it's true that someone did think you were an idiot, say you're doing a talk, say I'm doing a talk and someone thinks, oh, that person's crap. I shouldn't say words like that if I'm being taped, I guess. Actually, but anyway, but then you say, so what? You can't please everybody, right? So how do you respond and in your mind think when you're having these anxious thoughts? And that goes to the catastrophic thinking, overestimating how bad a particular outcome would be. So if someone doesn't like my talk, is it really that bad? How awful will it be? Could I manage? So that's what we're doing when we're doing cognitive therapy. We're really trying to look at, different ways of thinking, whether it's looking at the evidence, gathering evidence, considering other perspectives for the trigger, and also modifying the perceived cost. Like, how would you cope in that situation? And would it really be that bad? What would you say to a friend who is having a thought like that? So really getting people out of their head and stepping back to examine their thinking. And I do it all the time. That's how I keep going, is I do cognitive therapy on myself. That's the advantage of being my psychologist. Okay, moving on to behavioral strategies. It's really sad, but it's true. You cannot get over a fear by just sitting in a room talking about it. You actually have to go out and actually confront what it is you're afraid of. And people are like, I don't want to do that. And that avoidance is what maintains it. But what we try and do, so that's called exposure. And we try and do it in a really gradual way where it's all fully in the person's control, really stepwise. And I'm going to show you an example of how we do that. And we also at the same time try to reduce those safety behaviors, like no longer checking with people for reassurance, or someone's afraid of driving on the highway, only going during non-busy times, that sort of thing. And then we also may use behavioral experiments, like where someone could go test out one of their anxious thoughts. Maybe they have an anxious belief, and see if what they're predicting would happen really does happen. So they gather new evidence. So in exposure, we're really identifying the triggers what are the things that people are avoiding because of their anxiety, and then in a gradual controlled way, get them to practice being in those situations using what we call an exposure hierarchy, which is a list of the situations organized from lower anxiety levels to high. So you can see for Jason, playing a round of golf with his friends, putting him back in that kind of really initial situation that triggered the panic, or where he experienced his first panic attack, was 100 anxiety on his exposure hierarchy. We're not starting there. We're starting at the bottom. Go to the driving range. When he thought about going to the driving range, his anxiety was a 40 because he could leave easy. He was by himself. And you can see there's a bunch of different situations there that as he practiced each one, the remaining ones reduced, and he started to get his confidence back. So in about 15 sessions of CBT, Jason was back to work. It was a real feeling, and he's back, golfing and doing all sorts of things that he had stopped doing because of his panic attacks. That doesn't mean we completely eliminated the panic. It's just it wasn't interfering with his life anymore. He knew how to manage it. Because that's the thing. People often, when they come for treatment, they say, I want to get rid of this anxiety. It may not be that. Anxiety may ebb and flow, especially if you have a lot more biological vulnerability to it. And so then how do you manage it so you're controlling it and it's not controlling you? And we have some guidelines on how people practice the exposure. And the more you practice, the quicker it goes. And I wanted to just, I see the time, I'm going to just go a little quicker here. CBT, although it's great, isn't for everybody. Not everybody responds to CBT. Not everybody wants CBT. It's work. It's like if you're doing piano lessons and you don't practice in between the sessions, it's not going to work for you. So you actually have to practice the strategies. And some people just want to talk about, why do I have this anxiety? Where did this come from? They just want to talk or get support, and that's fine. That probably is not going to fix the anxiety, but some people don't want the CBT, and then they may want to consider other types of options. I'm not saying there's other there could be other treatments that could be available, but the first line treatment of CBT may not be for them. And so you have to be motivated. The person has to, be ready to engage. And sometimes it's the timing of it. Maybe they're not ready now, maybe at a different point. So I just wanted to point that out, that it's not like we get 100% treatment response in trials. It depends on the disorder. With a phobia and CBT, we almost have 100% remission. Whereas say OCD, it's a lot lower, it's much more persistent. People get significant improvement, but we may not be fully, curing the disorder. How do I get CBT? A good place to start is your family doctor, because they know the referral options in your area. There's also self-directed CBT using a workbook, and we have a whole bunch in the resource list. And there's private CBT in your community, so through psychologists or social workers or different private psychotherapists. And then you can, as I mentioned, there's a resource where you can find people who are trained in CBT through the CACBT website, which we have also on the resource page. Now, in the self-help category, we have, that's where you work on it on your own, and you start to empower yourself to feel like, okay, I'm going to try out these strategies. And that could be guided with using a coach or unguided. There's also apps that can help you with that. Here I just showed us, a few different workbooks, and on the resource list, there's a whole bunch more, but you can go now and there's workbooks for every particular type of anxiety problem. It's better to get a workbook that's specific to what your fear is, because that's just going to be more tailored, even though there are more general ones like, the anti-anxiety workbook here you can see is more general on the CBT strategies. There's workbooks for kids and teens, which we also have in the resource list, as well as a bunch of different websites that provide the low intensity options that you can check out and are in your resource list. And I mentioned there's mobile apps that can be helpful that, some are for a fee and some are free. Someone had asked about mindfulness and whether mindfulness is part of CBT or compatible. Mindfulness, which for people who are not sure, maybe not as familiar, although most people are familiar with it now, is just a way of being in the moment and a way of interacting with the world where you're being more observing, non-judgmental. It could be a way of interacting and being in yourself, or it can also be a meditation where you actually do a mindfulness meditation, a style of meditation. There's apps called Headspace and Calm that lead you through those meditations, and people can find it very relaxing. It can help them step back from anxiety symptoms. The evidence, is showing that mindfulness has promise for treating anxiety. Right now, it's been used mostly after people have tried CBT, and, it's gotten them some symptom improvement, but they want to try something else to maybe augment it. So we just did a trial where we looked at mindfulness for OCD after people had had CBT, and it did help them get further treatment gains. Mindfulness has also been combined with cognitive therapy for an intervention that's been effective for preventing relapse and depression, and is also starting to be more and more researched in anxiety. So it's definitely something, I think if it was me or my family member, I'd want to start with CBT, but it certainly doesn't hurt to have some mindfulness, and especially for relaxation, is a good strategy. Internet-based CBT, where they have different programs that use a coach or a trained therapist. And in Ontario, it's free through the Ontario Structured Psychotherapy Program. However, there are other programs that may charge a fee, and we have some listed on the resource. I just wanted to spend a minute, just the last minute here, talking about the Ontario Structured Psychotherapy Program. Now, I don't know how many of the 743 people on this webinar are in Ontario, but if you are, the amazing thing is the Ontario government has started funding CBT, and the website is there, both for the West region, which is if you live anywhere kind of all the way to London, Tobermory, Hamilton, that's the Ontario West region, or even Toronto or north of Toronto or East Ottawa. These two web links will take you to all the sites that are providing OHIP covered CBT. They have, most people start with the low intensity, it's called bounce back, and then it can up level to ICBT and even one-to-one CBT with a mental health clinician. That's all covered by the government, and it's for people who are 18 and over with mild to moderate symptoms of any of those anxiety disorders and depression. So that's a really exciting thing that's been happening and actually just rolled out in our region, but it's rolling out all over the province right now. It's getting up and going. So I wanted to just wrap up there, and this is just the summary that hopefully from this evening you are appreciating how prevalent anxiety disorders are. And even if you don't have symptoms of an actual anxiety disorder, having chronic symptoms that what we call subclinical symptoms can be very distressing and impairing and may warrant attention. And that's where that guide that can be really helpful in helping you know where to start. And CBT can be a really great option if that's something that you want to consider. So now I think we have time for, we have 10 minutes or so or a little more for questions.
Yeah, so that was excellent. Thank you so much, Randi. I've been doing my best to try to respond in writing to some of the Q&A that have been posted, but let's try to get through as many of them as we can. So the first question is that I've developed severe anxiety since the tragic passing of my best friend to a murder, and developed great sense of fear as a result, terrible loneliness. Can you suggest or recommend a particular treatment? And I think one thing that was highlighted in the chat, and as we answer some of the questions, I think we'll try to make them more general teachable moments rather than sort of medical or psychological treatment advice. So, I guess maybe thinking about something like this, where there's been a tragic event like this, and challenges emotionally afterwards.
Yeah. And so, I mean, so sorry for your loss. That is, such a terrible thing to have happen. And generally when very bad things, and none of us make it through life without bad things happening. Traumatic events actually have a high prevalence rate. There's a natural process of responding and feeling anxious and lonely and grief. That's normal to experience after you've had a traumatic experience. And usually, within 1 to 3 months, people's symptoms may resolve. But if you are finding, even after 4 weeks, or if it's really interfering with your ability to just live your life, that it's worth then going to get some help for it. And, people can develop post-traumatic stress disorder, which is where they, have all sorts of thoughts. It can interfere with their, sleep, re-experiencing symptoms, thinking about things over and over again. So grief and loss are commonly associated with that. And so, that OSP program would be a good program for PTSD, or symptoms like that, anxiety after grief and loss, going to your family doctor, or, looking at kind of what are some of those programs online, or seeing a private therapist. So I think that can really help people get through after experiencing really traumatic events. And there's also support groups that can be very helpful. Sometimes feel like being with people who've also experienced similar things is a source of comfort.
That's excellent. How do you identify whether you're depressed or have an anxiety disorder?
Yeah, and so often, as I said, you may have both. So about 50% of people actually do have both. They kind of go hand in hand. Depression is really characterized by feeling very sad, down, hopelessness, withdrawing from doing things, and can often happen after anxiety or vice versa. And so, I think that the first step, really identifying, are you not enjoying things anymore? Are you feeling hopeless about the future? Do you feel like you're thinking more negatively about the world or about yourself? Any of those types of kind of signs may be suggestive of symptoms of depression. And so starting with the family doctor or any of those resources might be helpful, because the workbooks, and there's workbooks for anxiety and depression, they go over those symptoms and you can see, oh, does that resonate with me? Does that sound like what I'm experiencing? And then you can see that there's really good strategies for depression, just like we have for anxiety. CBT can be very effective. It's a first-line treatment for depression as well.
I think one of the things that we see clinically as well is that many people suffer with anxiety disorders for many years, and the first time they go to see their doctor about it is if they've had a depression superimposed on top of it. So it's good that they're seeking help, and it's good, and hopefully the depression gets treated. But if the underlying anxiety disorder is not assessed and recognized and treated, they will also be at higher risk for recurrence. So important to, try to talk to your doctor if you feel like, hey, I have underlying anxiety symptoms, even if it's led to a depression.
Yeah, and I think that's a good point, because there's stigma. Sometimes you feel like, oh, I feel embarrassed to go talk about anxiety. I had a person who had a phobia of pigeons that was so interfering. She actually didn't travel for her jobs because she could have to go to places where there's pigeons, until she saw an Oprah session on treating phobias, and then she came forward. So I think recognizing that we all experience it, it's universal, can hopefully make people more comfortable to go and talk to people around you to try and see, well, where's the help for that?
There's a couple of questions related to other types of therapies. How, for example, does CBT, Cognitive Behavioral Therapy, compare to DBT, or dialectical behavioral therapy?
Yeah, that's a great question. And so CBT is kind of like a big umbrella, and you could package pretty much any a treatment strategy can fit under CBT if you're targeting people's thoughts and behaviors. And DBT, which was developed by Marshall Linehan, is a form of CBT. It's just a particular treatment package of strategies, but it's based on strategies that target cognition, behavioral strategies. It's actually very behavioral. And the main focus of DBT is emotion regulation. And it's one of the treatments that are used for people who are having borderline personality disorder or other syndromes where they're having their emotions like really feeling dysregulated. It's hard to control the emotions. They may feel like hurting themselves as a way of controlling emotions, or turning feelings off. So DBT is it's sometimes referred to a third wave CBT, but any of those can be packaged under that CBT umbrella.
That's great. There are so many great questions. We'll perhaps go a few minutes over to try to
I'm happy to go over. I'm excited by the question. So let's go. Let's go for it.
So here's a great one. It's this person started having panic attacks while being a passenger in a car, and can no longer travel on major highways, and doesn't feel comfortable driving on highways. Do you feel that this person would be able to drive again after CBT?
Absolutely. So yeah, you know what? This is a common one we see. When you have a panic attack, whatever you're doing when you have that panic attack, it's going to be hard to do. And as you see with what you're describing, anxiety tends to, generalize. Oh, I can't do that. Now I'm having trouble with this highway. And now, because I avoided those highways, I'm having trouble with even smaller highways, and it starts to snowball. The avoidance starts to snowball. So absolutely, driving phobia or people who are having trouble driving on highways, what we do is we build that exposure hierarchy. We often get involved a loved one who can help by, first we start, maybe the person's a passenger in the car, or maybe they start practicing. Maybe we start on a highway that's not as scary, that's less crowded, and we move up the hierarchy. But we treat lots of people with driving phobias, bridge phobias. A lot of people who live near Hamilton have a fear of the Skyway. I don't even like driving over the Skyway. I don't even like it. So, and there's another one on the way to Niagara that's terrible. But anyways, absolutely, that can be tackled. It's, it takes work and practice. And like I said, having the loved one, but the therapist will often go right in the car and will be in the back seat while a family member or partner is helping with the exposures as well. And then between sessions, the person drives with the family member or a friend who's helping support the exposures. And it's stepwise, so you do it gradually.
How can we convince, in quotes, loved ones that they have some form of anxiety or an anxiety disorder? Is it something that people should be self-aware of, or not really?
Well, that's a doozy. That's a loaded one, because see, a lot of times we can see our loved one has a problem, but if you try and broach that, they may not be open to it at all. So, I mean, I think it depends on the situation, the context. They may get defensive. They may not like it. I think if you think the loved one has anxiety, just checking in with them in a way that asks them, hey, I noticed that, you seem to be uncomfortable. Are you feeling anxious? Or disclosing your own anxiety might help them express themselves. But you know, for some people, you may be able to see it, and even if they may not A, acknowledge it, or B, want to treat it, and then there's nothing you can do. We've had lots of family members want to bring people for treatment, but the person doesn't want treatment. And unfortunately, and sometimes that's like an 18-year-old and you're the parent. And if they don't want to engage in treatment, it's very hard to sit by and have your loved one suffer, but ultimately people have to want to come for treatment and participate.
Here's another one. How can someone deal with the anxiety of the unknown, such as pregnancy or for example, the delivery of the baby or health of the baby?
Yeah, that's a great question. I mean, anxiety in some senses is all about the unknown and the uncertainty. And in fact, we have quite often we have uncertainty in all areas of our life, but people will zone in on one particular area. Like in this case, it's like pregnancy. And that's often a feared time for people and can be very interfering. I've even seen people who didn't want to get pregnant because they had lots of worries about outcomes and bad things happening. And we would use the same approach, start to tackle, well, let's try and see what are the predictions that are being made and start to tap into those anxious thoughts. And then how do we counteract them so that the person can actually start to consider, okay, well, what's another way to look at this? How do I challenge these anxious thoughts and feel more comfortable? So we would use the same strategies and just really try and monitor what the actual fears are. And often people say, well, very broad fears, and we want to get very specific. Well, what actually could happen? Let's go through each of your fears and really unpack it.
Yeah, that concept of anticipatory anxiety is such an important one in anxiety disorders, isn't it?
Exactly.
We haven't had a lot of questions about medications. There is a medication question here. This is a person on an older type of anti-anxiety medication, clonazepam, which is a type of benzodiazepine. And they only take it occasionally on an as-needed basis. They find it very effective for reducing and managing anxiety. And then as a result, they're reluctant to try anything new. So thoughts on this? I guess what we could say is just like CBT is a very effective treatment for anxiety disorders, there are also some effective medications. And some of the most commonly prescribed medications, like clonazepam or benzodiazepines, are probably overprescribed for anxiety. They're actually no longer the first line treatments, but they continue to be the most commonly prescribed. They can be useful in the short term while starting somebody on another medication, or if they're so impaired that they can't participate in something like CBT. But there are a lot of potential side effects. And so I would say very important to discuss this with your doctor if the decision is made to switch to medications or to use one of the first line medications, which are mostly in the family of SSRI medications. But there are a lot of people in your position that are on an older drug or a benzodiazepine, and I think especially in older adults as well, we do see a wide range of side effects in terms of effects on balance or cognition. So I don't know if you have any other comments on that.
Yeah, and we have there's trials out there using CBT to help people come off of those medications. So you can actually, it's very effective because you also develop a psychological dependency on the medication. You think, I can't get better without this. I'll have anxiety if I come off. And there's also rebound anxiety. People get anxiety when they come off the medication. And CBT can be a really useful treatment to help someone reduce on that medication, maybe come off completely, have a course of CBT to see if that's helpful. And if it's still persisting, then add in one of the newer medications.
Great point. Does child separation anxiety factor in here? This is a case of a younger child, a 4-year-old boy who doesn't want to go to Sunday school in this case.
Okay. Yeah, it's really important to consider the stage, because kids maybe naturally have some separation anxiety at various different stages. And some kids they're a little more anxious with newer situations than others. So it also depends on the child and their personality. And but CBT can be really a good approach. It's the same treatment that we use for kids in terms of helping to just break it down and get them more comfortable. And so how do you help for that child make it more fun, pair it with something like, my own child was nervous to get on the bus, and I would just say, oh, well, we're going on the bus for school, but I would be giving them Oreos and just trying to make it fun and help break it down. I would talk to the bus driver to, so she could give them extra support. So can you go visit the classroom Sunday schools with your kid, have some Oreos or something, you know what I mean? How can you get the kid more comfortable in whatever that situation is, and really use a hierarchy? You can break it down into little steps and then maybe it's going with them, or maybe they have a little buddy you can pair them up with so they feel more comfortable. So you can think of, how do we take this scary situation where I'm not with my parent in this big room of people I don't know, and then make it much more comfortable for the person. But lots of kids, especially certain kids, have harder times with transition and new things, but you can use these same strategies to tackle it. And we just adjust them accordingly, depending on how old the child is, in terms of how we talk about anxiety, like scary thoughts, that sort of thing.
Here's another great question. How do you know when medication should be used? Should it be at the same time as CBT, or should CBT be done first? And which medications are best to start for young adults or late teens?
Yeah, I mean, that's such a great question. Like, ideally, you don't want to start two interventions at the same time, because you don't know, well, which one's working, okay? And so I think it really requires going to your doctor and knowing what are the pros and cons of medication, what are the pros and cons of CBT. I can't really think of many cons other than it does require work and time. And especially if someone can't even go to school or function, that's when you may think, okay, if they can't even engage in treatment because they're so anxious. Sometimes we see people so distressed, they can't even engage in the treatment or monitor the thoughts, then medication may be considered. So I think really thinking of what the advantages or disadvantages of each approach, and then you start one and then give it a full trial. Like, it takes a certain amount of time for a medication to work, see if it's working, and then you can add in the other treatment if it's not working. Like with CBT, we want to give it a full test to see, like I said, it's 10 to 12 sessions. Well, let's give you a full dose and then see, where's your level at? Is it reduced? Is it manageable? Or is it still very high? And then you want to consider maybe going on a medication.
I think some of the other questions that people have had to kind of relate to access to CBT. So one question was, what's the average cost of a CBT session? And then another question was, what's available in Ontario for under 18s?
Yeah, that's a great point, because I think access, one upside of the pandemic, if you could think of an upside, is the ability to do virtual treatment, which makes it, you can access it anywhere. Now, in Ontario, it's free. Other places, it may not be. So there is a cost potentially, or depends on what services are available in your area. And that's why asking your family doctor, they usually know what resources are in the local area. The government covered CBT right now is for people 18 and up. They will be bringing in treatment for younger child and youth, but it's downstream. So it's really about looking at where in your community is CBT offered. Most communities would have CBT programs for kids and youth. Like in Hamilton, all those referrals go through a place called Contact Hamilton. But whatever your local area is, starting with the family doctor, again, I know I keep saying that, but they know what the resources are, but that should be accessible. And then also there's those workbooks I mentioned. It's a good place for parents to start. So because as a parent, I know from my own child, my child has OCD. Right from when he was 5, we were working on it at home and the strategies, and it's helped him manage it so it doesn't interfere.
For the Ontario structured psychotherapy, does it have to be referred by a family physician?
No, you can call or yourself. I think there's that web form, the link would take you to a web form, but I'm pretty sure people can go access it themselves.
So there's another question here that's interesting. Is some anxiety caused by a chemical imbalance in the brain? And are there cases where only medication will help?
Yeah, that's a great question. We do know that there's alterations in your brain when you're experiencing anxiety, alterations of neurotransmitters. That's the mechanism that, when we're taking SSRIs, it's changing, your receptivity to, neurotransmitters and your uptake. So that's what they're called, the selective serotonin reuptake inhibitor. So we do know there is imbalances per se, but What was the second part of that question?
Just it isn't, I guess the answer is, just because there may be chemical imbalances or genetic factors does not mean that CBT or psychological therapies won't work. Because I think the implication here was, oh, the chemicals are imbalanced, so you need a medication.
That's right.
But that's actually not the case.
Yeah, because even stressful life events can trigger you to get imbalanced, right? So like that's like the stress chemicals. So yeah, so absolutely. And in fact, there's a really cool study, actually it's in depression, which compared a medication treatment and CBT, and they looked pre-post at the brain changes, and the CBT, both the brain changes were there, whether you had CBT or medication, they were in different places. The people got better from their depression, and both interventions targeted changes in the brain, but actually in different brain areas, which was really cool because you can change your brain as you're changing how you think and behave. You're also changing your brain.
When we learn something new, our brain chemistry changes, and similar studies, I think in OCD have shown pre and post psychotherapy or medication changes with cognitive behavioral therapy on brain imaging. So
exactly,
you can change your brain with psychotherapy as well. I'm just conscious of the time we have had. I mean, it's been such a pleasure to have you tonight, Randi. I think what we will try to do is answer some of the questions that did not get answered tonight when we put together our e-learning lesson on the portal. I think that's probably our best bet to try to answer some of the other questions. There's just a couple of other things that I want to highlight before we go tonight. The portal, we will be launching this anxiety lesson in the next month. You can go to McMaster optimalaging.org and the subscribe button to subscribe to our email, our weekly email with evidence tips, and then you'll be alerted for when our e-learning lesson on anxiety comes out. We also post, the e-learning lesson will be in the e-learning section. We'll also be posting a recording of this session on the portal in the videos section, and it will also be on the Alumni Association channel and also on the portal's YouTube channel. So if you didn't catch the whole event, or you want to share this with a family member, there's a couple of ways you can share it. One of the other questions that came in through the pre-submitted questions was around anxiety and dementia, and our igericare.ca resource has a lesson on anxiety and depression in the context of dementia. So I think those were just a couple of the things. Stay tuned as well. There's a short video at the end of this. Our next session's coming up at the end of the month. I really hope you'll be able to join us October 26th, another Wednesday, and that will be same time, cannabis use for common conditions, looking at the research, facts and fiction with Jason Bussey and James McKillop. So I really hope you'll be able to join us then. And can't thank you enough, Randi, for tonight's webinar. It was fantastic. And thanks everybody for your questions.
Thanks, everyone.